Thank you very much, and thanks for inviting me to participate in this international forum, which at least using Zoom allows us to continue to provide mutual education to each other. I very much enjoyed the last talk. So maybe I'm a little bit of a fish out of water in this, in the sense that my background is as a neurosurgeon. And I'm going to tell you about a collaborative effort that we have worked on at the University of Pittsburgh using radiosurgery to treat now choroidal metastases and uveal melanoma cases. These are my conflicts of interest related to prior relationships and some of the professional societies that I've helped to work on. So stereotactic radiosurgery may not be familiar to everyone. It's now almost 70 years old as defined. And it was set up by Swedish professor Lars Leksell in Stockholm to deliver in a single session highly focused radiation by cross-firing individual beams using a variety of technologies. He started out using a simple orthovoltage dental X-ray device, and then moved in the 60s to using a proton beam in collaboration with Börje Larsson at the University of Uppsala. But eventually the gamma knife was developed in 1967, and while his primary interest was in the treatment of functional cases, that is pain movement disorders, he developed this to be able to, as it evolved, to treat a variety of things. So while it began as a primary role in the gamma knife for functional brain surgery over the course of more than 35 to 40 years, it's been widely used for tumors, vascular malformations, and in fact, both benign and malignant brain tumors are the most frequent usages at this time. So what is the difference between radiosurgery and radiation therapy? There are a variety of technologies that can safely deliver focused radiation in a single procedure. And this has become possible because of huge advances not only in imaging, but also in mobilization of the target in order to restrict dose to the lesion while minimizing dose delivered to the surrounding tissues, which is where risk comes from. So in the delivery of this in a single treatment, the standard concepts of radiation therapy basically are not relevant, which look at the repair, reoxygenation, repopulation of a tumor cell. And while there is no direct correlation between the radiobiological effectiveness of a single treatment versus fractionated radiation, as a general example, an estimate of a 4-to-1 biological effect can be used. So for example, a dose of 20 gray delivered by focused radiation using radiosurgery may be equivalent to 4 times that effect of fractionated radiation therapy of 80 gray. So single session radiosurgery, as we do it with the gamma knife, and has been used worldwide in many centers, and I'm pleased to hear about the work which has been ongoing in Athens for many years. Now more than 1.25 million patients have been treated. This has led to an enormous population of patients, chapters, books, peer-reviewed publications, and a wide variety of clinical indications have emerged based on skull-based tumors, vascular malformations, functional problems, and of course, metastatic cancer. As a general concept, it is got a surgical training bias in the sense that everything is done on the same day. Imaging, planning, and treatment are completed, and this makes an enormous convenience for patients and families. Now, as you're aware, there are other options, and you will hear more about that, I think, today. Generally speaking, plaque therapy, a usage of conventional linear accelerators, protons, maybe in some rare research centers, carbon ion treatment. As a general concept, this is done by multiple sessions over the course of time. It's been based on the traditional radiation therapy concept that cancer requires multiple hits in order to be able to reduce the to increase the radiobiological effectiveness and hit multiple cell cycles. But in the case of an eye lesion, you must be able to immobilize the target. We believe that there's a significant benefit of reimbursement. Healthcare costs go significantly down using this particular technology. Now, in the course of the brain, which is where I have focused, there are in the United States more than 1.2 million patients diagnosed with metastatic disease. Many of these patients will develop cancer spread into the brain, with many having met 300 to 400,000 new cases per year. At our center, we've treated more than 17,000 patients over the course of 34 years using the Gamma knife, and certainly the largest number of patients that we treat are related to metastatic cancer. And there's a wide variety of other indications depending on functional, vascular, and tumor cases. The general procedure is done with the patient having eye conscious sedation. And as you're familiar as ophthalmologists with doing a retrobulbar block, we can immobilize the eye. We can then put on a stereotactic head frame. We do high dose imaging or high definition imaging using MRI at that time to define the target, and do dose planning either with prospective or inverse options. And we deliver a dose in a single treatment at the margin of the tumor of 16 to 20 gray, meaning the maximum dose at some point is typically getting 32 to 40 gray in a single procedure. So we then go to frame removal and the patient goes home on the same day. So I'm going to take a couple of minutes to show you the general process of the procedure. We start out with a retrobulbar block to paralyze the eye with a member of our ophthalmology team. And once that's done and the eye is now paralyzed, we can then go and do the imaging. But first we must put on a stereotactic head frame, which we see here by putting on local anesthetic and then attaching this with guiding pins to the front and back of the head. It's very important to have short pins in the back of the head in order to restrict collision risks in the future. We then do the imaging, and the imaging is transported into the Gamma Knife Planning Center, and we can see the target very well on MRI using long TR imaging, T1 with contrast, and T2 imaging. Once we develop the computer plan, and we do this relatively quickly because we certainly don't want the eye to wake up and start being able to move during the actual time of treatment, we then develop in collaboration with our oncology colleagues a plan to do the treatment. These are typically done with the patient's neck extended, and that's because the target is very far in the front of the head, and we want to be able to avoid collisions since the focus of the beam is going to intersect obviously on the eye target. Once the procedure is completed, the patient comes out. We simply remove the guiding pins. We put small bandages on the head. At this point, we observe the patient for an hour and the patient goes home. So I want to review a study that our group recently published as a meta-analysis looking at outcomes related to radiosurgery and then comparison to other techniques using both fractionated radiation therapy, protons, and brachytherapy. This was the first author, and this is Dr. Tariq is currently a first-year resident in neurosurgery training at Mass General. He did this while getting his PhD at Oxford and collaborated with our group in putting together this data, which led to a final review of 28 studies in the final analysis with almost 900 patients. The average age of the patients was 62, and average margin dose was typically in the 20s, with maximum doses around 32. The important thing is this led in these publications to local tumor control in 93% of patients. And in fact, we see tumor shrinkage or regression in 79% of the patients with follow-up imaging over time. Of course, there are risks of complications related to even very focused radiation, and yet compared to the other options, these I think are relatively acceptable. The risk of glaucoma, which we were actually concerned about would be much higher, has been relatively low. There is a risk of radiation-related retinopathy, in part related to tumor volume, but the need for a subsequent enucleation of these patients has been quite low. If we add all of the potential complications in this, about 50% of patients reported one or more complication. Vision acuity was stable or improved in 24% of patients, which is related, of course, to the severity of the risk of the or the status of the vision prior to the actual procedure. We did not find any relationship between the dose that was delivered and the tumor size. And in fact, what's happened over the years, there's been a gradual dose de-escalation because the doses that were thought to be needed in single session radiosurgery were much too high, and in fact, much higher than doses we would deliver for patients with intracranial brain tumors. As an aside, we often find patients who have not had an MRI scan before with melanoma or choroidal metastases. And when we do the procedure to treat the eye tumor, we find brain mets at the same time on the same MRI scan, and we treat those on the same day. There is no difference in local tumor control between Gamma Knife and I-125 plaque therapy. And in fact, compared to conventional fractionated radiation therapy using linear accelerators, there was improved local control with radiosurgery with the Gamma Knife. Here are three examples of lesions we've treated over the course of years. The upper one is a 73-year-old male with a ciliary bottom melanoma, which we now heard good evidence is a bad prognostic feature. Here's a patient with a choroidal papillary thyroid met with nice response over the course of time. And here's a patient with a non-small cell lung cancer choroidal met with a regression over the course of time. So of course, these patients continue to be followed by the ophthalmologist who's looking at visual acuity and be able to do direct vision retinal studies, but we find MRI scan to be very helpful as well. So again, I want to reemphasize that a relatively small percentage of these patients need enucleation, which of course has been a standard treatment at many centers. If we look at the overall survival meta-analysis at 5 years, and we've heard great data relative to the impact of this tumor, depending on variety of molecular findings that are found. In this study, 76% of the patients had the survival using Gamma Knife, similar to what was protons and brachytherapy, and actually better than those patients who had already undergone enucleation. So the advantages of this compared to brachytherapy and enucleation and proton beam are widespread, reduced healthcare costs, admission costs, of course, with enucleation, immediate blindness and cosmetic difficulties. Proton beam is very expensive, requires centers, and for many patients in smaller countries, of course, transportation and expenses related to do that. So in general, this meta-analysis of all these various options certainly indicates that Gamma Knife is a very effective, cost-effective care with non-inferior outcomes to more traditional usage techniques using plaque, protons, or enucleation. We are part and the coordinating center for more than 37 worldwide centers that are looking at outcomes in a variety of indications who will undergo radiosurgery. And we think that actually the involving centers who are able to do this for ocular tumors might also be able to give us a better long-term data in the future. So thanks for requesting our participation in this study, and the opportunity to present. Someday I would like to get back to Athens. I must say that 50 years ago, my wife and I did our honeymoon in Greece and spent a month there, including 2 weeks in Crete. And my hope is that eventually we might be able to get back there when the healthcare issues of the world resolve. Again, thanks very much for allowing me to participate.